what is trans-affirming psychiatric care? What are some of the essential attitudes that we need to be bringing to this care? And we'll review psychiatry's historically complicated tradition with minoritized groups and discuss some specific examples of this that you might be aware of, some you might not be aware of. We'll identify the dynamics that are present in provider-patient relationships and define components of affirming and non-affirming psychiatric care. So let's first start by talking about psychiatry's history with trans and gender diverse communities. First, a majority culture will consider a non-conventional way of being, so being trans, being gender diverse, being queer, as wrong, as deviant, and inherently threatening. Stage 2 tends to be pathologizing. So it's still an assumption that this non-conventionality is wrong, but looking for some biological reason for it, looking for a way to categorize it. Can't help it, was just born this way. But it's still locating this non-conventionality as something that is a problem, something that is inherently wrong, but because the person is ill. And then the final stage would be accepting it as a normal variation of a human trait. And so we've seen this trajectory happen with gender diversity and with sexual orientation over the years. And we talk about this because psychiatry and medicine play a huge role in halting this progress by stalling us out in pathological. Because pathological serves as a shorthand for less real, less valid, and it's something that can be used to take people's power away. And psychiatry and medicine are used to enforce cultural norms. And there are multiple specific examples for how this has been written into standards of care, and it's also been part of practice. And with regard to sexuality, I think many of you know that homosexuality was in the DSM until 1973. You may or may not be aware of the activism that led it to be removed from the DSM in 1973. So this is Dr. John Fryer, was a gay psychiatrist in the 1970s, but he made a speech at the annual APA conference in 1972 in Dallas, Texas. He had to do so wearing a Nixon mask. He was in disguise during this speech, because that's how dangerous it would have been for him to speak up in a room full of his peers and argue that homosexuality is not pathology. This is a normal variation in a human trait. So, the elephant in the room, or the latent content in the room, from a psychodynamic perspective, is this: the history of psychiatry being leveraged as a tool by the dominant culture to enforce social control. And this is worked through pathologizing deviance and seeking to fix or treat things that are normal variation in human traits. So how does this end up playing out for patients? So this looks like hypervigilance. This looks like a patient coming into the room, being nervous, being unsure what they can share, what's safe or what's not safe. Coming into new relationships with patients, and I can feel the hypervigilance that's in the room. I know that I think I'm a safe person, I think I'm very affirming, and that I'm going to do what's in the best interest of the patient, but I haven't built that trust yet. And so I don't take it personally. I just know exactly what that feels like to come into the relationship and not be sure if this person is going to actually take care of me or enforce harm. And then one of the last dynamics in the room is a history of medical gaslighting. So it looks like interrupting the patient, not allowing for elaboration on a topic so they don't feel heard. It looks like minimizing or downplaying symptoms. And if the patient is reporting something that you don't understand or something that doesn't seem plausible to you from your level of education and training and experience, it might mean jumping to consider what's the secondary gain here, or having an assumption fairly quickly of personality vulnerabilities. And I say this having been the provider who jumps to these assumptions when presented with something that I don't really understand the patient having. And it's also an attitude. It's an attitude that fails to presume that patients have expertise and competence about themselves that surpasses our own. And I think it's really easy for us to say that we have this attitude, but when we get in patient scenarios, when this comes up, what we're actually doing is we're not presuming patients' competence, we're presuming our own. So what drives medical gaslighting? I want to talk about the individual factors that can drive this behavior in all of us, but also systemic factors that can drive it, because I actually think the systemic factors are more interesting, pervasive, and have a bigger impact than individual factors. But we'll go with the individual first. So one of the first things that can drive medical gaslighting is just non-understanding. If there's a condition that we don't understand, that someone is reporting symptoms of, then that can drive us to dismiss or downplay them just because we don't understand what's happening. It's a bit like the blind man and the elephant parable. If you don't know the blind man and the elephant story, it's essentially a fable where a number of blind men are exposed to different parts of an elephant, and so therefore they describe the entire being based on what they're able to perceive. So one person will describe the tusks and feel it as like the smooth ivory and describe the entirety of the elephant based on the smooth ivory. You touch a leg and sort of feel the rough texture of the skin, and so on. And so it's essentially claiming to understand an entire scenario when in reality we're looking at it through one particular lens. And that one lens is our training and our psychiatric training, but also our own perspectives, our own experiences based on our identities as well. I will tell you, some of the most powerful and trust-building things I've ever said to patients has been when I've said, I don't know. I'm not sure. There is a sea change happening with regard to awareness of neurodiversity and neurodivergence, because the paradigms that we were given in our training were really based on cisgender males. And the way that autism presents in people who are assigned female at birth and socialized as female are simply different. If you don't have exposure to these communities and have seen it, then it's really easy to downplay. And then I think this one is incredibly important to just sit with for a moment, that we are all vulnerable to having this fear-based desire for control and predictability. We have to be able to admit when we're not sure of something and be able to hold just how much we can control in clinical scenarios and in clinical outcomes and what we can't control. But the thing is, when we feel afraid, when we're not sure how something's going to go, when someone is making decisions about their treatment that cause us to feel anxious about what they're doing, certainty can feel like an oasis in the desert. And this fear-based, contracted certainty, or illusion of certainty, rarely comes up in ways that are affirming to patients. What does this look like? Or everybody's coming to me with ADHD, influenced by TikTok, everybody just wants stimulants, and so I'm not going to prescribe them categorically because everybody's just trying to get this medication. Or insert your controlled substance here. I think we can have this attitude a lot around controlled substances, because the fear is around our license being implicated in overprescribing controlled substance medications. And please believe me, I am not advocating for irresponsible or reckless prescription of controlled substances. What I'm saying is that fear can lead us to desire certainty about a situation, and that certainty is an illusion. And so this desire for certainty can lead us to make decisions that are very contracted, very rigid, and are not affirming to people's experiences, are not open to what people are actually going through, because this certainty is a mirage. So those are some of the individual factors that I know can drive medical gaslighting, but let's talk about the systemic factors. So first, a culture of cynicism. So a culture among physicians, a culture among practitioners where you get together and you complain about all the people who seem to be drug seeking, about all the people who are coming forward with disability applications. So, and that leads into what really drives cultures of cynicism, as I've already touched on a bit, not having enough time for appointments, not having enough time for admin work. It's incredibly difficult to stay open-minded and open-hearted. You don't feel connected to other providers. You don't feel like your needs are getting taken care of. And as they say, it's impossible to pour from an empty cup. Or you have to tell a narrative to the insurance company about progress and improvement because that's just what they expect to hear. It becomes so easy to blame individuals, when the truth is that the models we have in place to be able to view these cases are completely detached from reality, completely detached from humanity, and all about progress and outcomes. So the best way that I could sum it up in a single sentence with trans communities, with marginalized communities in general, is that Affirming psychiatric care lives in the tension between gold standard evidence, what people and communities are telling us about themselves, and other innate ways of knowing. Because practicing this way means embodying a number of the principles that we've talked about before. This is inherently right-sized. It's humble about the limitations of our perspectives, of research and gold standard evidence. It's respectful of the fact that medicine and science have not served these communities well in the past, and actively works against the more harmful paradigms in medicine that have been used against these communities. So I think that this style, this philosophy, is the wise middle path that allows us to continue to ask questions, to stay curious, to never be certain, and be critical thinkers who are paying attention and listening to our patients. For how to describe this to patients, an affirming perspective also sets the limits that you need so that you can stay regulated and be your best self.